We are honored to have Dr. Zhidong Deng, who is a health scientist with the Centers for Disease Control and Prevention, and also Lisa Nelson. Ms. Nelson is an informatics consultant from Life Over Time Solutions. She has been very actively engaged in supporting many of the profiles and the work within Qrph. So we'll start with Dr. Deng.
Okay, thank you, Michelle. Good morning, everybody. The profile we're going to present is the quality measure execution early hearing. This is a profile actually that spans both the quality and the public health domains of Qrph. So as you may know that nearly all U.S. jurisdictions have established an early hearing detection intervention or EDI program to help identify children who are deaf or hard of hearing and to ensure they receive recommended follow-up services. The information required to measure the quality of the EDI process, such as newborn hearing screening, is available at the EHR systems of the healthcare providers. The newborn hearing screening electronic quality measure was one of the 29 clinical quality measures in the CMS Meaningful Use Stage 2 program and was recently adopted by the Joint Commission as one of their 6 required steps for hospitals to satisfy their accreditation and certification process. Recently, there have been some major changes, revisions to the quality measure standards such as QDM, HQMF, and QRDA standards. And the QMEH profile that we are going to present today is going to show several ways in which implementers of the measures can leverage these new developments to improve the way quality reporting is done and to alleviate burdens of surveillance and quality management for care providers and public health programs. So, Lisa?
Thank you, Dr. Deng. Next slide, please. To improve our capability to measure the quality of newborn hearing screening, 5 use cases have been addressed by the QME EH profile. In 2 of the cases, information is shared directly between the EHR at the birthing facility and the information system at the public health agency. In the other 3 use cases, a middleman system is added to facilitate the flow and processing of data. The 5 use cases describe variations that result from shifting 3 core processing responsibilities between these 2 or 3 systems. The responsibilities include producing a summary of care document, which includes information about the hearing screening a baby received during their birth encounter, generating patient-level quality reports, and computing aggregate-level quality reports. Next slide, please. To support this broad set of processing permutations, the QME EH profile defines a modular technical solution. It establishes a single composite actor that groups together 3 component capabilities. Consuming specific types of standard input files is one of the capabilities that this composite actor has. A second is processing those input files according to a given quality measure definition. In this case, a newborn hearing screening ECQM measure definition. And then third, generating specific types of standard output files for that processed information. 2 of these composite actors can interact to achieve the 2 system use cases, or 3 can be combined to achieve those 3 system use cases. In each scenario, each system actor simply does more or less of the data processing tasks associated with summarizing that clinical information and producing the patient-level or aggregate-level report. Next slide, please. Let's look at an example of how this modular technical solution applies to achieve use case 4. This was a scenario where the birthing facility only has to produce a summary of care document, like a CCD or a CDA discharge summary in the U.S. realm, which it has to do anyway because it needs to support transitions of care. A second system in the middle processes that data to produce the patient-level quality report and then uses that information to compute the aggregate level quality report. And then a third system, the Public Health Information System, only has to consume the aggregate level quality report that was produced. In the top right-hand corner, you see some red highlights that indicate which of the profiled processing options each of these systems needed to implement in order to make this particular information flow possible. Next slide. The Qme EH profile offers several benefits. It shows different options for implementing ECQMs, so you can find one that best fits your situation. It aligns with the CMS guidance for electronic clinical quality measure reporting associated with the eligible hospital incentive programs, and it shows how to apply those general guidelines for the newborn hearing screening measure, which is called CMS 31 or NQF 1354, which is one of the 29 measures, as Dr. Deng mentioned, that can be submitted to qualify for those eligible hospital incentives. And after you've followed the instructions in Qme EH to implement the newborn hearing screening measure, the other ones that you have to do will just be that much easier. This is a low complexity measure, so it's an ideal way to demonstrate your system's leading edge data analytics capabilities to support standardized execution of electronic clinical quality measures.